Dear friends, so we can start. This section is dedicated to women's health. My name is Anastasiia. This is my colleague Olha, doctor hematologist. I am a proctologist, and we are going to speak about women's health. I believe that this section is the most medical of all the topics that we've discussed in the last 2 days. I hope it will be interesting for you and you will find something useful for your medical practice, something you can implement in your daily work. Is there anyone who's not a doctor here? Okay, there are a lot of people who are not doctors, but I believe that you will benefit from it. So let me invite our first speakers, Dr. Hladunewich. I believe that's one of the most interesting and most charismatic speakers of our forum. She is our colleague and great friend from Canada, and she will tell us about preeclampsia. Apart from her volunteering, she is also a nephrologist, right?
So what I want to talk to you is a little bit, which of your women are at risk? We'll start with the epidemiology and the risk factors. It's going to be very kidney centric because I'm a nephrologist, but I'm going to tell you about the risk. We're going to review the recent pathophysiological understanding about preeclampsia because it actually now gives us biomarkers. So you could diagnose preeclampsia with a biomarker now at the bedside. And then finally, we have to talk about the long-term sequelae to both mom and to baby. This is not a disease that ends with pregnancy. So we need to pay attention. If there was ever a time to make the women and children of Ukraine healthier, it's now. So we really want to pay attention to preeclampsia. So this is Canadian data. So 63.6 per 1,000 deliveries are complicated by maternal hypertension in Canada. Hypertension in Canada is actually the leading direct cause of maternal morbidity. So this is preeclampsia is the leading cause of why women die in Canada when they're pregnant. And eclampsia complicates about 50 out of 100,000 deliveries. Everywhere in the developed world, preeclampsia rates have actually been going down, except one notable exception, the United States of America. And this was before Vonizdolile, because it's going to be even worse. Because if women can't get reproductive care, then they're going to be left in more severe situations, and they're going to have to carry very at-risk pregnancies. So if you look at their curve, maternal mortality is actually getting worse in the United States. I wanted to look in the literature to see what happens in a war-torn zone, like what happens to women's health in a war-torn zone. And like conflict-affected countries actually do account for 64% of global maternal deaths, despite representing only 25% of global maternal births. Maternal mortality disparity is much higher in a conflict zone than a non-conflict zone. And this results, and there's vulnerability, preventable maternal deaths are obviously going to happen more in a conflict zone. And that's not going to be all across Ukraine, obviously, but it is impacting women of Ukraine. War does not cause preeclampsia, but the chronic stress from conflict can cause inflammatory biomarkers to go up, cortisol levels, hypertension. You can have difficulties accessing resources for women that are preeclamptic. Before a pregnancy in Canada and you have kidney disease, you have to see me so I can spend many, many months with you to make you perfect before you have your baby. When you're in a war zone, you don't have the access like that to the specialists because they're busy doing other things. And then, of course, there's delays in transport, delays in treatment, depending on where you are. So this is, women's health is a really, really important topic right now. I wanted to see if there was anything published on preeclampsia in Ukraine, and I actually couldn't find too much. So again, if you're collecting this data, it would be very useful to publish this data. But there was one study that showed birth complications. There was a 12% increase in obstetric complications at Ukrainian maternity hospitals. Cesarean section rates were a bit higher, which kind of makes sense, because if there's an emergency, you may need a cesarean section. And there was only one study that looked at sort of birth weight, and it looked like overall babies were smaller since the conflict started. So women's health needs to also be prioritized. So what I want to impress upon you today is that preeclampsia affects 5 to 7% of all pregnancy. At least in developing worlds and other parts of the world, the incidence is increasing. In Canada, that's because when we have our babies, ми дуже старі. You guys have your children younger, good for you. In Canada, we all wait, and then we have really old mothers. So, but same with the US, we wait. But women are coming to pregnancies with more comorbidities, okay, more hypertension, more diabetes. So these are the things that are increasing preeclampsia rate. And also IVF. If you need to have your baby with IVF, well, that also increases your likelihood of preeclampsia, irrespective of other factors. And then, of course, global instability. There's actually data on climate change and rates of preeclampsia going up because of climate change. So preeclampsia is very serious. It accounts for over 500,000 fetal and maternal deaths worldwide. Sorry, 500,000 fetal, 70,000 maternal deaths. And for every death, there's 100 near misses. And I have beautiful young women who, yes, they didn't die, but they had a stroke or they had something else that's going to change their life forever. So really paying attention to preeclampsia is really necessary. And the graph there on the right is actually showing you that severe preeclampsia is the one that's going up, all right? All right, so let's talk about risk factors for developing preeclampsia. So there's many risk factors. Your family history, you could always ask a woman, does your mother have preeclampsia? Because you're more likely to have preeclampsia. It's the same as if you had cardiovascular disease. If you had cardiac disease, if your mother had cardiac disease, and we're going to talk about why that is in a moment, but preeclampsia puts you at risk for cardiovascular disease. First pregnancy, multiple gestations, advanced maternal age, in vitro fertilization. But the women that you should concentrate on are those with medical comorbidities, because those are the ones that you can actually improve their pregnancy outcomes. You can't predict which nulliparous woman is going to develop preeclampsia, but you can know that a hypertensive woman is going to develop it, or a woman with diabetes, or a woman with kidney disease. So spending time optimizing those women before a pregnancy can really improve their outcomes. So as I said, I'm a nephrologist. So I'm going to share with you a little bit of my research. I find my own research rather interesting. You might not, but this is a study that we did a number of years ago, and it's very interesting, and it shows that one of the most important organs in preeclampsia is the nerke, it's the kidney, okay? This is a study of recovered acute kidney injury. That means something made your creatinine go up. Maybe you had a UTI, maybe you had reflux, maybe you took too many nonsteroidals, but you had an episode of acute kidney injury. The worse that acute kidney injury was, the higher your likelihood was of future preeclampsia, and that's after your creatinine normalized. So sometimes we don't pay much attention to bumps in creatinine. Oh, it's okay, it came back down. But even resolved kidney injury increases the future risk for preeclampsia. And in fact, it doesn't go away for 18 months. So if you had a woman who had severe acute kidney injury and she right away wanted a baby, you might want to say, "Чекай трошки," because you got 18 more months and you are going to have a higher risk of preeclampsia, a higher risk of preterm birth, and a higher risk of a low birth weight baby. So I take care of women with more advanced stages of CKD. This is my research. So this is the province of Ontario. These are all the births in the last sort of 10 years in the province of Ontario. And we looked at their GFR pre-pregnancy. So what was their kidney function? And I put your attention to the preeclampsia one over here. Do I have a pointer, Chini? No, yeah, my pointer. Бачите там preeclampsia? Look at that one, okay? So I look at the preeclampsia one. If you look at that one, the worse your GFR, the higher your level of getting preeclampsia. So the women that actually went into pregnancy with advanced kidney disease that had proteinuria, because you could have advanced kidney disease and you didn't have proteinuria, your risks are not that high. But if your GFR is less than 45 and you have 500 milligrams to a gram of proteinuria, your chance of having a preterm baby is actually 50%. Okay, so that's a very high rate. And then add to that diabetes, add to that hypertension. So every one of these risk factors that you pile on these women further increases their risk for preeclampsia. So it is really common. If a woman has IgA nephropathy or reflux or something, she usually also has hypertension. If a woman has diabetes, she usually also has hypertension. So these women that have these diseases need very special care prior to pregnancy. So let's move now to what's new in the pathophysiology of pregnancy. Are any obstetricians in the room? Oh, Дуже добре. Okay. Then you'll understand this because I usually speak to nephrologists and they don't know anything, right? So it's good to have people that know what I'm talking about. So you could correct me if I'm wrong. But what we understand about the pathophysiology of preeclampsia is actually a two-stage process. And the reason why these women with hypertension, kidney disease, diabetes get preeclampsia is because they have abnormal placentation. Their placental vessels do not develop a deep, nice flowing placenta, and these women have shallow placentas. And then what happens as the baby grows, then these placentas become ischemic and they start to release angiogenic factors, which I'm going to talk to you about. And that is actually what is preeclampsia. So the first stage is poor placental implantation, and the risk factors for that are all the risk factors that I told you. And then the second stage is the maternal endothelial dysfunction. And for many years, we didn't really understand what caused maternal endothelial dysfunction. And now we actually do. Okay. And this is actually an amazing discovery. This was made by a colleague of mine about 20 years ago now at Harvard Medical Center, a very nice nephrologist, not an obstetrician, a nephrologist, who figured out this pathophysiology of preeclampsia. But when the placenta becomes ischemic, it releases anti-angiogenic factors, soluble FLT, soluble endoglin. That will actually then bind to the factors that we need to maintain a healthy endothelium. Okay, so vascular endothelial growth factor, placental growth factor, those should be in very high levels in a pregnant woman. So when these binders come around, they sop it out of the woman, then she goes on to get endothelial dysfunction. So what does that mean though? That means that we now have a biomarker for preeclampsia. So in Canada, I can actually measure this. So there was a study, it was done in the United States. They had a large cohort of women with preeclampsia. They measured these biomarkers and they used it as to diagnose. It wasn't as good as diagnosing women as it was as ruling out preeclampsia, but that's also really important because then you know you could move to the next patient because they don't have preeclampsia. In my population, the kidney disease, it actually helps me diagnose preeclampsia because they already have hypertension. They already have proteinuria. How am I supposed to figure out now that they also have preeclampsia? So this was a really important biomarker, and you can see the negative predictive value was much higher than the positive predictive value. And all the stuff we do at the bedside, we check their blood pressure, we check their liver function, we check their platelets, they perform very poorly compared to this biomarker. All right. So this is a study that me and my colleagues just completed in Toronto, and we did these biomarkers prospectively through a pregnancy. We looked at them. They all had women with kidney disease. And what we wanted to know is, can we use it first to prognosticate and can we use it to diagnose preeclampsia? In the third trimester, it had prognostic value. But at the time of diagnosis, it really helped me figure out if I was dealing with a woman with preeclampsia. And it's always good to have an example. So she allows me to bring her picture all over the world. This is one of my patients. She's an absolutely beautiful young woman. She was on dialysis. So I take care of a lot of pregnant women on dialysis. I've helped manage about 50 to 60 of them have babies on dialysis. And she came to the clinic with quite a high blood pressure, but we could not figure out, and she was about 28 weeks gestation, and we really couldn't figure out, was this preeclampsia? Was she volume overloaded? Were we not taking enough fluid off on dialysis? We sent, the obstetrician wanted to deliver. You know, I had to say Chakai, right? The obstetrician wanted to quickly deliver. And I said, just wait, let's get the biomarker back. And it was stone cold normal. It was 0. I took her back to the dialysis unit. We took off more fluid. We added methyl-dopa. She eventually delivered at 36 weeks gestation. So this is a really, really wonderful advancement in obstetric care. Now, there's also now, which is really important, a point of care. That means even when you're somewhere that's not accessible, you could get this point of care, Alere. It just measures placental growth factor. And right now we're studying it in my lab to make sure it performs as well as the ratio. But if it does, this is something that could be taken anywhere in the world, to a Ukrainian hospital, to help diagnose at the point of seeing a young woman, am I dealing with preeclampsia? So we're going to end with sort of why I really love preeclampsia because they've become my patients forever because I'm a nephrologist. So what are the long-term sequelae of preeclampsia? And it's really important that we actually pay attention beyond that. So it's in Canada, just to give you an example, I have an obstetrician who's my partner, and we do everything together. Go out drinking together, everything, like everything. She's my best friend and my partner. We can't be without each other because she can't diagnose kidney disease without me, and I can't diagnose preeclampsia without her. But after the baby's delivered, then they all become my problem. All right. So then they all come to me after 6 weeks gestation. So you have to understand what's going to happen to these women after preeclampsia. So we now know that preeclampsia is a vasculopathic state. Okay. So after you have survived preeclampsia, you're at a higher risk for peripheral vascular disease, coronary artery disease, stroke, hypertension, and end-stage kidney disease. And if you're a tiny preterm baby, you're also at higher risk for CKD, chronic kidney disease, and hypertension in your future. This is one study where they were sort of looking at the odds ratio for hypertension, and they found that basically if you had preeclampsia in the first 6 months, your chance of being hypertensive was 18 times higher than women who didn't have preeclampsia. By 6 to 12 months, it was still 6 to 12 months, it was still 4 times higher, and by 1 to 2 years, it was still 7 times higher. So women now it is possible they had hypertension and they didn't know it because they came to care late. But it's more likely that they had these endothelial factors and all of this, swimming around in their system, and their endothelium has changed. Now, we sometimes call preeclampsia a stress test. So women that get preeclampsia have failed a cardiovascular stress test. Maybe they were predestined as well to get cardiovascular disease later in life, even if they didn't have a child. But I always tell my women, don't worry. I know we've diagnosed you to put you at higher risk, but that means we can change things. We can quit smoking. We can manage your hypertension. We can manage your weight. And that gives women a lot of control and power over their future. We did this study, a colleague of mine did this study a number of years ago. It's a very big study of 1 million women, of which 75,000 of them had some form of preeclampsia. And what was notable, he did show again that cardiovascular disease, coronary arteries, cerebral vascular disease, peripheral artery disease were all higher. But what's also very interesting is it matters how severe the preeclampsia is. So preeclampsia with preterm birth is the highest risk for future vascular disease. Late onset preeclampsia, not so much. All right. And this is a very famous preeclampsia study from the Child Health and Development Studies cohort. And the reason I show it shows the same thing, that women develop heart attacks after about a preeclampsia. But this is what scares me. Look at the median age at which these women started to develop heart attacks. Is that old or young? Thank you, because I'm 56 years old. I would have felt terrible if you would have said old. But this is exactly when women are starting to get their heart attacks. So these women need really, really careful attention as they age. Now, because I'm a nephrologist, we studied this with one of my cohorts. It's called CureGN, it's cure glomerulonephritis. Just so you know, we haven't cured it yet, but we've gotten a lot of interesting data out of it. And this is a self-reported pregnancy outcome study. And what we found in those women who had a preeclampsia or a complicated pregnancy, they lost more GFR per year than women who had a normal pregnancy. What was actually kind of interesting is women who had a normal pregnancy lost less kidney function per year than those who never became pregnant. So there might be something actually protective vascularly about a completely normal pregnancy as well. This is a nice study from Taiwan, and it basically shows much of what I'm already telling you, is that there's a significant increase for CKD and an increase for ESRD. So women that had preeclampsia are going to reach end-stage kidney disease sooner, and they're going to reach it in higher volumes. And it does matter, again, what it showed is gestational hypertension, not as much, preeclampsia more likely to reach end-stage kidney disease, and severe preeclampsia is even more likely. And it does make sense. We know that at the level of the kidney, you've not only damaged your endothelial layer because you've got preeclampsia, But there's something called the podocyte, which is part of our, I know, and only a nephrologist cares about the podocyte, which is a filtration barrier. We know that you lose those podocytes during a pregnancy complicated by preeclampsia, and you can't grow them back. So there's a whole bunch of reasons why your kidney becomes particularly at risk after you've had preeclampsia. But it's not just the women, it's also the babies. So it is so important to have healthy women and healthy babies, because preterm babies, although we can do a lot with neonatal ICUs, they actually develop their glomeruli, their filtering units of the kidney, actually proliferate at the end of gestation. So when a baby is born very preterm, they don't have the same endowment of nephrons as a baby who went to term. And later on, that baby is prone to kidney disease and hypertension. And in fact, now I actually have these babies in my clinic because I'm old. So I've actually I delivered them, and now these children are actually my patients as well. So just to summarize, and I wanted to leave time for questions, preeclampsia is a common and a severe disease in women with medical comorbidities. Understanding the physiology has been really revolutionary because now we have biomarkers and we can set up programs even in remote areas or areas that are not easily accessible to diagnose preeclampsia. Women will go on to have increased morbidity and mortality as vasculopaths, vascular disease. Their children will go on to have chronic disease. So we need to target women's health over their entire life cycle. It's really, really important. So war may make this worse. And I think because you guys are in this situation, it would be helpful if you can gather as much as your data, just like in the posters that we just saw, which were just excellent. The data that you have gathered is going to further the literature and further our understanding of these difficult diseases. And we need to have ongoing urgent research to help meet these unmet needs of these mothers. I did look up what you have done, and you've done a lot of amazing work. I was very impressed. You have emergency obstetric equipment distributed to 61 Ukrainian maternity hospitals, magnesium sulfate availability, mobile incubators, underground delivery systems, fetal heart rate monitoring that are battery operated with portable Doppler ultrasounds for mother. You developed preeclampsia management protocols with snappy algorithms, and I forgot it. So I guess it's not snappy enough, maybe Yazdev Zabula, but it was a very good algorithm. And you guys are staying here and you're taking care of your patients, and that matters. And it's our job to keep coming back to help you take care of your patients. So I thank you for your time, and I'm happy to answer any questions.
Thank you. I'm obstetrician, yeah. And the high-risk pregnancy is my theme. So we really have a lot of IUGRs and preeclampsia for last 3 years, and the amount of pregnant women that have these complications is much bigger than before the war. I think that's because of a lot of factors.
Course, many.
Yes, but when we're talking about preeclampsia, it's like cardiovascular causes and the placental causes, and they can be together and not together. But the question is, okay, yes, we have a SFLT PLGF ratio that we can use in the second and the third trimester, like prediction. Will this woman have the preeclampsia in at least 4 weeks after the ratio? And we have the first trimester screening for prediction. Will this woman have the risks of preeclampsia?
You're using your PAP-A, right?
PLGF.
You're using PLGF,
Yeah, we use the both. Because we can, and our standard in Ukraine for now from 2023 tells that we can use or PAP-A or PLGF as an option if we can. My hospital can.
It's not as predictive early in pregnancy as it is later.
Unfortunately, the biggest problem is the early preeclampsia, and we can't good predict it. So PLGF and SFLT ratio helps us. But do you use in Canada first trimesters biochemical screening also?
Yep. So I took that slide out. I should have left it in. But we do a few things in Canada. So we'll look at the first trimester screen at PAP-A, of course. We do Dopplers every time we see them. So every woman will get, you know, a ultrasound that'll include the placental anatomy. After 18 to 22 weeks, we do Dopplers. We're looking for notching, resistive indices. So we're doing all of that. And this is just additive, right? Like it's helpful. It's helpful because it's something else. Nothing takes, no biomarkers ever takes away being a smart doctor at the bedside and really paying attention to your patient. But it is helpful because a lot of women that come with chronic disease, they already have some hypertension, they already have some proteinuria. They're the hardest population. So they're the ones where I find it is, and our studies do show that it is diagnostic in those women. Predictive, in women with chronic kidney disease, it wasn't predictive in the first or the second trimester. It was only predictive in the third trimester. So I don't think that we still have a really good marker for early pregnancy to know exactly who's going to get into trouble. I think we just have to use our, you know, our risk stratifications and look at them and then, you know, decide who we're going to follow. But you already know that any women with chronic disease, hypertension, these are the women that are going to be the high-risk women, right? So they should be already in high-risk clinics watching them sort of throughout the pregnancy. And then for other preventative strategies, we do give calcium, you know, because based on the Cochrane analysis, and we give everybody aspirin, of course, like as I'm sure you do for preeclampsia prevention. It's just sort of, you know, but that first, we don't really have a marker that says for sure she's going to be the one to go on to get preeclampsia.
Thank you.
Дякую за те, що ви взагалі приїхали в Україну.
Thank you for even coming to Ukraine. Thank you for not being afraid of it. I'm a doctor of pediatric and anatomist. You told that perhaps because of the translation, I didn't realize that you said that among kids born from women with preeclampsia, the risk of disease, there is a risk of kidney disease. What in this case do you recommend to do to neonatologists and the pediatric workers? How can one observe these kids? What are the peculiarities of looking out after this?
Yeah, you do me, Rozumio. So I think you're asking what can we do for these babies, essentially, that are born premature. There is a literature out there. There's actually, believe it or not, encourage breastfeeding. Breastfeeding helps reduce the risks for baby of hypertension, and the main thing is obesity. Because when you have too few nephrons and then the baby becomes obese or gains a lot of weight, that is actually more damaging than for the kidneys. So maintaining sort of breastfeeding is actually one of the most important things that we should be encouraging. Sometimes women with high blood pressure, they're worried and all that. We have the drugs. There's very few women who cannot breastfeed. I allow my women on dialysis to breastfeed. So that healthy nutrition for babies so they don't have a very big weight gain after being very small is protective of their kidneys. Прошу.
Дуже дякую. Маєте ще хтось питання? Будь ласка, поки буду йти, скажу, що у нас після мене...
So tell that after me there will be a speaker who is a consultant on breastfeeding. And I'm pretty sure that she would be happy, definitely was happy to hear your answer. По-перше, велике
SFLT PLGF ratio while we are screening patients on their 30 weeks of gestation. I mean, other kind of like preventative measures we can do while knowing that they have the risk of preeclampsia on their 30 weeks of gestation, because we know if we can screen patients right on the beginning of their pregnancy, we can give the aspirin right before the 16th weeks in gestation and having like the best results in advance. So do we have anything to do with the results of SLT ratio?
I think she asked the same question, but it's not as predictive earlier in the pregnancy. It's more the risk assessment for, you know, even if you look at some of the full peers or those where they're using those risk assessments, they're a little bit later on, right? So it's not great in the it's not good in the first trimester. We tend to see our women at 12 weeks in Canada. So usually I see them early. We see them at 12 weeks. If they have any high risk factors, we put them on aspirin. So I don't know, do you reserve aspirin for a certain population here, or do you put everybody on aspirin?
Well, like those who are at the risk. So we do like a kind of like a questionnaire right before they starting their journey, like through the pregnancy at the beginning, and then if they have the high risk, we will give them the aspirin.
Yeah. So
in
very
order to
similar
prevent.
practice to what we're
So
doing.
just as I understand, it's just because about like SFLT and PLGF ratio. So it's just for the reason to make them hospitalized, to be hospitalized if they have
it
that
could be
ratio?
for the, so it has better negative predictive value. Okay, so it's the reason not to make them hospitalized, right? So you can actually rule out impending preeclampsia, and then maybe they don't need to be hospitalized. It doesn't have as good of a positive predictive value. But if you're somewhere and you're in triage, she's got a bit of hypertension or whatnot, you don't really know what to do with her, the ratio can help guide you. Like I can give you like an example. We had a woman she was overweight, she was chronically hypertensive, and she actually didn't look any different than she did every other visit, okay? But a little bit of hypertension, like she looked the same. We did the ratio anyways. She didn't really have any symptoms. Her ratio was sky high, and within 6 hours, she evolved to help. So we called her back into clinic, and we admitted her. And then in others, we actually prevented an early delivery because we were able to say, and now we still follow them very carefully, and we will repeat it again in about 2 weeks to see what the trend of the ratio is. So that's sort of our practice in Canada.
Okay, thank you so much. Thank you.
So, dear colleagues, when we within our team have decided that we will be doing the section on women's health, I realized that I cannot but be here because there is one very triggering and painful topic that simply harasses me. And as our yesterday's speakers recalled, Mr. Pavlo, if you recall, and not only him, I guess somebody else also talked about this. But all in all, there is a problem that is much painful for me, and I would really love to share with you this problem. If you haven't heard about it, this one, if you have, maybe you will discover something new. If not, then pay attention, please, to this one and do your own reflections on this. I'd like to start with such a slide and to show you visually what is the real problem we have with the birth rate in Ukraine. Please pay attention. 2020, what kind of column this is in 2024. If we take a look at the numbers, in 2020 in Ukraine there were born almost 300,000 children. In the 2024, as you can see, gradually it was declining. It is approximately 170,000, meaning that it is clear that there is war. It is clear that many women of the fertile age moved out of the country. It is clear that because of some conditions, the will of having kids right now is has degraded among people. However, we cannot but tell that we don't have any problems we cannot impact. There are some problems about that, yes. And we have to analyze all of them and to necessarily create conditions for the modern women and in a proper way to say for the modern families, young families, for them to be as motivated as possible to increase their families, to have more Ukrainians in the world, and for us as a nation all in all not to extinct, because it's a global question, right? There are many moments about this, and I'm pretty sure that if I ask each of you, why do we have such a small birth rate in Ukraine, you all will tell about infrastructure, about finances, about war, first of all, obviously. But there is one more, not that much seen problem, but very much painful. And this is what I call oasis. Has somebody heard what this is? Please raise your hand. Great. So as you can see, it's not about that very desert. But what is this? That's the trauma of anal sphincter. You see how painful this picture is? And also, honestly, when I saw this picture first time, I had this kind of pain in my groin. What is this? Is when during the birth a woman receives critical trauma of the muscles of hips and anal sphincter. A little bit more in detail about what precisely this oasis can be, because that's abbreviation. It can be of the third and fourth stage. When it comes to the third one, you can see how it is graded. And the fourth one is when everything is ripped off and this vaginal obstacle tissue is ripped off. And this is the rip-off of the fourth level. And now look at this phrase at the very bottom. Women come out from birth department without knowing what oasis is. Can you imagine this? They don't know about this. This is such a serious trauma. And how is it happening that women do not know about this? And I will tell you a little bit later. So all the studies that are there in the world, not in Ukraine right now it's not being studied. These all studies tell that there is a short-term and long-term complications of oasis. So what does it mean for a woman? If a woman has this oasis, what does it mean for her? Well, first off, that's physical deficits that she has, so-called physical oasis syndrome. It can be chronic pain, the pain in the groin that can be reinforced during sitting or walking, not being able to keep the urine or feces. And not like as you think that a person is wearing diapers. No, it can be possibility to hold up the gases, some leaks that can be shown as the irritations in the anus area. That can be also the obstructive defecation syndrome, meaning that a woman feels like she wants to go number two, but she cannot. So the decline of the vagina walls. And some women come to the doctor and there is a diagnosis like rectocele, and in sometimes they do not see that yes, indeed, there is this kind of decline of the walls of the sphincter. But that's also the problem of diagnostics. And these kind of women have sexual dysfunction, meaning that they can have very painful feelings during coitus, or on the contrary, the absence of any feelings at all. And very often their libido goes down and all the far-reaching consequences. And one has to recall about the psychological oasis syndrome. If these kind of things happen to a woman, very often then this woman is facing the depression state, and this very much impacts her possibility to act as a mother, meaning that there is this kind of notion as act as a mother. And these women, it is quite complicated for them to take care of their child and to fulfill all typical for our functions. Very often they refuse to do the breastfeeding. Very often they refuse to take care of the child and all these moments. And most important, well, one of the most important when it comes to looking at a precise woman, not as an individual, but us as Ukrainians and as a nation, then these women simply refuse from giving birth in the future of children, even though they had this kind of plans. Meaning, as long as I've been working with this kind of women, and they all would say that I don't have anything against 2 or 3 kids. I've been dreaming about big family, but after I had this that happened to me, I will never in my life will be given birth.
Let's speak about further complications of oasis. So it may result in rectovaginal fistula. And as a doctor who often treats this condition, it's very hard to treat according to the latest data. More than a half or approximately a half of women who had the primary operation on this fistula have it again. Thing is, rectum, there is some pressure in the rectum, and because of that, these fistulas can occur once again. Of course, it can happen not only after the pregnancy, after delivery, it can be complications of another disease. These women often suffer from pain and infection of their organs. In St. Mark Hospital, they faced 50 cases in the last 5 years, but Mayo Clinic faced 107 cases in 12 years. But in my hospital, we've had 16 cases in the last 3 years. So if you count the statistics and if you speak about percentage, we often face this problem, unfortunately. People say that it happens quite rarely. We're speaking about statistics of 2021. 42% of baby deliveries were the natural delivery process. And so people often tell me that the problems we are talking about is a rare thing. In 2021, there were 115,000 natural baby deliveries in Ukraine. Let's speak about world statistics. Let's speak about the statistics. Oasis can occur in half of percent up to 100.5% of the total sum of the natural deliveries. So if we calculate figures in Ukraine, we can see that there are a lot of cases of oasis. So what is the roadmap for us? Let's say a woman faced tear. There was a tear during the delivery. If that happened, a woman has to be transferred to the OR with all the necessary equipment and environment, and a professional that specializes in sphincter plastics have to come. Even if that's it can this specialist, this professional can come in 8 or 12 hours. Let's say if a woman experience hemorrhage, of course, in 8 or 12 hours, we can still have the surgery on sphincter. It's not a regular operation. Sphincter has very specific autonomy, so we have to have a professional who knows it well. Even if you followed all these steps and the perineum is not functioning well, in 3 or 6 months, we repeat that operation once again, having the professional that specializes in sphincter. And the most important thing in all of this story is that the woman has a right to know about it. But what happens in Ukraine? What happens in real life? Basically, this tear is being sewn in the delivery room. Usually, a gynecologist or proctologist does it, but it's not okay because delivery room and OR are different things. Then the woman is recommended not to sit for a long time. If the wound tears once again, they sew it once again. Then the woman is sent home. And when the woman suffers from some dysfunction, some incontinence, she is diagnosed with rectocella in a better case. And maybe in a couple of years, she'll be sent to a proctologist. This is a usual situation in Ukraine. So what do we have in the end? Unfortunately, maternity hospitals and their professionals don't know about it enough. They don't register those cases. They just try to improve the situation on the go during the delivery, and we do not collect data on these cases. We don't analyze the data. We don't learn from our mistakes. Why? Because doctors are afraid of talking about these mistakes. They feel ashamed. A woman who's delivered her baby, will write negative comments on social media. You can see some of these comments here. And so doctors try to conceal the truth. What can we do with all of it? These are my own reflections based on this topic. To be honest, I think we lack something in this reflection. That's why I want to talk about this problem publicly with you. Maybe you have some new ideas. What is the basis? We need to work with the general public by sharing the information. We don't do it enough, and Ukrainians don't actually understand that even the best hospital, even the best surgeon or obstetrician can make mistakes, and we can face complications. Complications is something that just happens. We need to accept this fact. It doesn't mean that we need to send this doctor to prison. We need to be aware of that. We also need to work on the relationship between doctors, because doctors can blame each other if they see that their patient, for instance, suffered from oasis and it was not treated right. So they would blame the doctor that didn't treat that condition. I also propose advocacy of doctors and holding people responsible for disinformation before we have results of official expertise if some doctor made a mistake. Presumption of innocence is still valid. I know some cases abroad when a patient were complaining on doctors on social media, but they didn't mention their surname because they knew if they do that before the court proceedings, they will be responsible for this. What else can we do? We need to fight the obstetrician violence and creation of comfortable conditions for young mothers. I used to think that home deliveries are a rare case, but I can see that they're much more common. My patients are often the women who delivered at their homes, and they often tell me that they delivered their first baby in the hospital, they were treated poorly, and then they decided to deliver their second baby at home. In case of complications, we need to use adequate roadmaps. And to have these roadmaps, we have to work on our mistakes, we have to register them and write protocols, create the roadmaps for the patients. Another thing that's needful is cooperation. I came to maternity hospitals, I had some proposals, but they are afraid of these proposals and they don't want to cooperate because of the mentioned reason. We need to have collaboration with proctologists, urologists, have workshops that we all take part in, and clinical cases discussions. Another point is to reduce risk factors as much as possible. There are some risk factors for oasis. These can be different conditions of a woman and of the baby. And the most important thing is prenatal expertise for the mothers. Women should be supervised by experienced obstetricians. And if they see the high risk for oasis during the delivery, they will not let those women have natural delivery. And the flowers, what will we have out of it? So this is what we aim for. We would like to have departments on pelvic floor physiotherapy. We have some departments in the country, but we lack them. We need to work on them. I think we can do physiotherapy through myostimulation by teaching women some exercises, but we don't have a fully fledged proctologic station with biofeedback and other functions. I would like to have support for young mothers and their children and social program aimed at involving men in raising their children. Maybe we don't face this problem, but a lot of families who don't understand the importance of it, they still face this issue. And the last point is to create infrastructure for children, and I believe that would encourage women to give birth. Thank you so much for your attention. Thank you so much, Anastasiia, for your wonderful speech. Thank you for raising these important questions. I learned a lot. It's something we need to talk about, something we need to share the knowledge of. And I believe by your blog, you also raise awareness on this topic. So are there any questions in the room? Tell me, please, is there something today for pregnant patients, something they can do to avoid oasis? I know that it depends on obstetrician, on their knowledge, but is there something the patients can do? Because sometimes patients come and they ask us what they can do. So I'm asking specifically about pregnant patients. I want to draw your attention to the fact that when women come, I never tell them that I never blame them for any complications or any diseases they face. That's a very important thing. What can a woman do? We're speaking about an average woman who is not a doctor. What can she do? She can have consultations with her doctor. She can be monitored. She can go to all the medical appointments for her pregnancy, but a lot of pregnant women just don't do it. She needs to come to microsonomy of the fetus because that's one of the key factors for developing oasis and the positioning of the fetus too. People sometimes, I would recommend these women to know the doctor who will help her deliver the baby, just to know that person and to be able to communicate with them during the delivery process. If you can do it, that's awesome. Of course, we want all the women to get the best care they can so that it doesn't depend on the particular doctor, but human factor still plays a role. So if you're anxious about it, meet your doctor before delivery. And I often see that pregnant women think about the music, the lighting in the room, but they don't ask questions about their health, about possible complications, about what they should do during the delivery, what they should expect. One of the factors of oasis is when a woman is delivering in a standing position. Some books encourage that, but unfortunately, obstetrician in that way has limited access to perineum. And statistically, oasis happens much more often if the delivery is in a standing position. So it's important to talk through all of it so that we can avoid these complications. Thank you so much. I'm also an obstetrician. You're speaking about pre-delivery consultations and cesarean section if there are some risks for oasis. We do have some protocols on cesarean section. All the information is in the protocols. Speaking about annex to protocols, if you talk about it, proctologists can write down that they don't recommend the natural delivery if women, if the pelvis of woman is injured or if their sphincter is injured. Sometimes women come to me and ask me to allow them to have natural delivery, even though they have all these complications. There are just some conditions that doesn't allow this labor. I was delivering a baby in a natural way myself, and I understand that cesarean section is worse than natural delivery, but oasis is worse than cesarean section. You have everything written down in the cesarean section. All of these conditions are spelled out in the protocols. But what I often face is that we lack expertise. We have this information in protocols, but we didn't examine our patient well, and that's why they ended up in that situation. Are there any other questions? Good day once again. There was a phrase that risk factor is first pregnancy is So is it because that woman doesn't have an experience in delivery, right? So it's important, so it's logical that this woman has to be their obstetrician. Is there statistics on partnership delivery and how they influence ACEs? There is statistics that partnership delivery reduces all the complications associated with delivery. So that's the first question. Is prenatal training, including breathing exercises, affect these complications? Olena is a doctor who was my doctor during my pregnancy. She's making. So we cannot. Let me speak about my experience. On the 1st of October, my daughter will turn 1. I knew a lot about delivery, but I didn't do anything I knew about it because it was very scary. It was terrible. Even though I had anesthesia, epidural that didn't work on me, it was still very hard. But the thing is, speaking about medicine, statistics on partnership delivery, I don't know anything about it. I believe that it should reduce the risk of complication, but I believe it also depends on the partner. There is no official statistics on it. Training, prenatal training. Yes, in some articles, it's mentioned that women who were more prepared to delivery, who understand the process better, were faced less risks. So sometimes it works against them because they decide to give birth in the standing position, but standing position is a risk factor for ACEs. So I also think that second delivery is easier, maybe not physiologically, but psychologically.
So Miss Olena is a very good family doctor and academy leader of UNICEF course on breastfeeding for medical workers, and the expert on eating disorders among children. And all in all, me, after I faced breastfeeding, I take very big responsibility and respect to consultants and advisors. Right. Thank you, Anastasia. Thank you to everyone who have come here in the Saturday Eve. But truth be told, when I today was networking with people who already I have, because it's a typical networking to talk to those who you already know since it's safe. And my lady colleagues who don't have kids yet, they ask me what my topic is. I was elaborating that this is my topic. They're like, hey, that's a cool topic. You'll love it. You can definitely do it in the right way. But other my colleagues who already have children, they would say, to be a mother and a professional is really complicated. And that's indeed complicated because the previous report of Anastasia had a big contraceptual effect on me. And perhaps I will just add up a little bit. That is why I'm sorry beforehand for those who was thinking about kids and will think deeper about that. But there is still a bunch of good things about that. Can we compare these two roles? Well, I don't know. Perhaps yes. I intentionally put here this in my narratives and thoughts. They are here simply to explain that while having some kind of subspecialization in the family medicine, I have some understanding of the complexities that can appear among women who are trying to work and who have children, because the complexities with nutrition, breastfeeding, or combining breastfeeding and work, that's exactly the competence. And while working with a family doctor, I have access to children as well as to their parents. And when I came to study for the nutrition therapist, I was mostly working with those children who do not eat. And I was writing down in my motivational letter for my grant, I said that I wanted to learn it because moms come to me who cannot give the child to the daycare and cannot go to work. They cannot find themselves in this world. And I would like to help them to do that, because that's indeed a problem. And the problem is that a mother is more oftenly coming with this very request, saying that, please, I need some assistance, at least for half a day, but I cannot give my child because he is not eating anything. Are there any problem now of motherhood? Because motherhood is different than it used to be, it's definitely, because back at that time, the maternity rate was mortality rate was higher, but right now there are some tendencies for improvement. And even in those countries that right now have the best medicine, back in the 19th century, the level of mortality among mothers was quite high. And we can see that one of the older women, even in Sweden and Finland, was dying in the 1800s. But right now it means one or two, well, in the 2015, there died approximately 300,000 women. Well, relatively it's fine because we can see on this chart that all in all, the general tendency is declining. There was a little peak that had to do with the coronavirus infection, meaning that back in time, the task of mothers simply was to survive. Now, it is much easier to survive. However, to recover and to later on to try to combine all that wave that is like launching on you, the way you have to be here and there immediately, both a mother and a professional, and do another job, well, that's a new task. And not always one can deal with that ecologically. Besides, in addition to you have to survive after the birth, but also there is a chance of receiving the complication. There is a good study that was done in Ukraine, and there were polled approximately and surveyed approximately 700 women. And let us agree, right now, for us to look at the world statistics, how women go through motherhood, and to take world data, that will be a little bit different from looking at the experience of Ukrainian mothers, because we are living in war state for the fourth year, and to take the data generalized and European one is not quite efficient. So we did the survey among mothers about the quote of the recovery back in 2025, and for the years 24, 23, they were polled and surveyed. I will be relying on this one in my report because this one is quite interesting, and as to me, it shows some reality. 4 out of 5 women in the post-birth period feel some kind of pressure of the society demands and expectations, meaning that these expectations can be quite different and feel different among different women. Yes, somebody gave birth, and the way she planned, the way they got prepared for this, that I'm gonna be with the child the way I want to, as long as I want to, and that's the motherhood. But in reality, even in addition to those women who, in addition to mother's role, do not expect anything, there is a society who expects something else from them. Every third woman was saying that she felt something but couldn't quite clearly articulate where she has heard about this. And truth be told, this also represents that very often one tells, well, you just make it all up. Nobody expects anything from you. But in reality, this very pressure and demands are articulated by women. What does it tell us about? It tells us that this very stereotype is so much deeply rooted now as a society standard or some kind of demand that even without some kind of precise comments, it still impacts mothers. Every third woman has heard something from parents or from mothers-in-law or fathers-in-law. Every fourth woman has heard something from another family members or relatives. That is why it is important to live separately from parents. Perhaps but this is my personal comment, I would say. But thank you so much for my daughter and to my mother who is sitting with my kid right now. One of 6 women has heard this about a partner or family member. The mostly widely spread stereotype was that there is some kind of precise, perfect mother who can do everything, to take care of a child, to take care of the house, to be a beautiful woman. And especially when one looks much at the social media. There, a mother in the maternity leave who takes care of the kid can not always have a force, a power to go outside, to talk, to spend some time in the community. Women spend much time on social media. and social networks. I guess that the women and the mothers of the young child, little child, you are just scrolling, shopping online, and they read all these. They see what's going on. Somebody went there, somebody came to the tours there, and somebody find time for this. And this is a pressure, even without comments from aside. And they think that individual holiday, that's about recreation and rest. If somebody of you has been on leave, that's the biggest lie we have ever heard, to call this as a holiday. But half of the women would say that, hey, well, you are on holiday, meaning that you are having rest right now. Okay. There was another syndrome described that in Ukraine, mostly we hear that from psychological workers as the bullied mothers. And all these mothers come to me, and I refer them or give some kind of recommendations. And very often we refer them to psychological workers, because it's literally about explanation of how it is like for you to deal with all this, until no pathology is. But women feel themselves a little bit bullied. There's much of scenes, and there are some surveys that per day a woman can spend approximately 1 hour 7 minutes for herself. What can one do within this time? Well, I don't know. Maybe to go to take a shower, maybe to eat something, to drink cold coffee while the child is sleeping, and that's it. All in all, the week of the woman is 89 hours. That's twice as big as the full wage. And women have too much sensory overload. And when I heard this psychological term, it's called sensory overload. Now I understand how it is like to describe this kind of things when you say, well, I'm exhausted. That's what we call sensory overload. Now I tell to my husband, I'm sensory overload right now. Please give me 1 hour to myself, especially when your work has to do with another people. And we doctors know it, and there is much of this kind of things in family medicine. But a child requires all those kind of touches, hugs, breastfeeding, common sleep, and so on. Definitely, this is perfect. Because in addition to what we say that motherhood is complicated, at the same time it is beautiful. But all those constant touches, sometimes you simply don't want anyone to touch you at all. And there is this kind of feeling that you don't have this private space at all. After I gave birth to my child, I realized why my husband finds a place in the toilet and can sit there for an hour without coming out. Now I do the same, because it's the only room in my apartment that has the lock and key. And multi-tasks, well, the research says that women fulfill 3 or 4 tasks. I think that's a light version, because mostly women are thinking about, okay, winter shoes, okay, you're already grown up from that. Okay, after school activity, now you have to pay for the school and daycare establishment. What am I gonna eat for the dinner? There is a bunch of things you manage, and this kind of work is not visible. It just seems that it's been solved out of the blue, even though a woman is planning a lot. And this kind of multifunctionality is solving work related questions and the home related questions. Before that, women did not hear any stereotypes about idealization of motherhood, because some of its complexities are being silenced, that one has to keep the perfect cleanness at home. And again, when social network is translating a lot of things, and to keep up the diet with the breastfeeding, and that a woman should be some kind of keeper of the home warmth. So to say, these are not very non-ecological stereotypes, because you cannot make it all together, and there is no need to do that. But these kind of things are being put on your shoulders. Some responders said for the stress and the priority of the career of a husband. And I think that not only women but also children feel it, because obviously a woman goes more often into the maternity leave, and statistics tell us about this. And very often a woman cannot be completely for 8 hours at work if she is breastfeeding, so to say, if there is no place where one can feed this child, meaning that a woman has to be at home more than a husband. But this very stereotype, meaning that, well, yeah, obviously, and if a husband goes on maternity leave, everyone's going to be pointing fingers and saying like, well, that's a man. But if a woman will be taking the maternity leave, nobody is going to tell anything. Well, she's just doing the normal stuff. When I had some kind of work TDYs on the trainings and so on, and my daughter was still small, she was left at home, and everyone would be saying to me, well, where did you find this kind of husband? He just, but in reality, it's just 2 days per week. Right. So this is not that much. And this kind of allocated partnership, that's a norm in the 2021, is the 21st century. The second question that tells, well, perhaps he's not a doctor, because if only he would be a doctor, then perhaps he will not be able to put the hold on his career in comparison to mine, right? And there is this kind of phenomena, and Juliana Maslak recalled about this motherhood penalty, that women after giving birth more rarely receive the leadership positions. And all in all, women occupy leadership position more rarely, and those with kids do it even more rarely. And some of them say that this is a personal choice, meaning that she made a choice to be a mother. But in reality, there is a systematic problem that is not supporting her in some moments, and the woman simply doesn't have any choice. And this is a choice made for her. The society puts expectations that a woman should be sacrificing herself because she has to take care of the child. And there is this kind of internal pressure, this kind of feeling of guilty. And this feeling of guilty, I think that when it comes to all my colleagues, female colleagues who I'm talking to, this kind of feeling of guilty that I didn't do everything I can or didn't spend much time. And today we had a pretty perfect panel discussion. And we also talked about this guilt feeling that I did not spend enough time with my kids, even though I had another question. Could I be here if only I would spend this time with my child? Because somewhere should be this kind of gap. Not always you can make it everywhere, and in different moments these are different priorities. And plus double load can also lead to some kind of burnout. The managers, as we know, mostly prefer women without children, and truth be told, this very foreign survey and the research, but in my bubble, there is a couple of companies who have quite a good reputation. They are good employers, but they have this kind of internal rule to look at who they hire. If this is a young woman who is not married or who has just a boyfriend, then she's not that much attractive candidate, because most likely she will most likely get married and will go on maternity leave. And when I was submitting my papers to one of the jobs, and I went through interview, and my potential employer looked at my RIN and said, well, you have the RIN, meaning that you're going to be on the maternity leave soon. Well, I did, but not because I just married, but because the work was not quite well. The drawback is that women receive less than those women who don't have children. It has to do with perhaps they have less shifts, less TDYs, but this is a systematic problem. That's not only a choice of the woman herself. The wages are lower, and sometimes, well, even if a husband or a father can be offered the career perspectives and the new position, because now he has a father, he has responsibilities, and sometimes it is easier for the man to move up these career paths and stairs than women. What is interesting is that there are different wages between the different and even 2 years before the birth and 1 year after birth, the differences in the wages of a woman and a husband duplicates. And within 10 years, it's all been kept, and only after that, this all is been equalized. Is this any kind of, well, some kind of financial harassment? Well, perhaps it's not harassment as it is, but the fact that woman does not receive enough money, does she need this money? Yes, of course. So this is the type of dependence. And recently, I've been there in social network. There was some discussion because there was a big agency that did not hire a woman, honestly telling her that, well, you have a child, well, our work anticipates TDYs, then we will not be hiring you. Not because the legislation doesn't allow this, but because you will not be able to do that. So why do I emphasize this? Because they told it honestly, because somebody else will tell, well, we found a better candidate, and that's it. Well, here, there's just a penalty that people told this, but that's a world statistics, because still women receive less chances for the career growth. There are some kind of biases at work, because there is this kind of stereotypes that a perfect worker, and I would translate this even as a definitely worker, will always be accessible, open in chats, respond in chats, doesn't have any kind of children holidays at the daycare or at school, nothing. Meaning that he or she will always be accessible. And this doesn't mean with this kind of image of the perfect mother who will be always next to her child. And for successful mothers, there is this kind of type of double punishment. What we can think about this, when you have this kind of success, not all the people are happy for you, and many of them are expecting, like, when will you finally give up, make a penalty, and then later on they will point fingers at you and say, hey, did you think that you really will be able to make everything on time with the kids? No, it's not going to be this way. There's kind of double accusation there is up there. And I see this kind of responses to the phrase, and it resonates not only in me, but I see it according with my other colleagues, because they tell it to me. There is a kind of good scenes in all this dark kingdom. A woman who has a child, a woman who is developing in her work, I think this is one of the examples of the impeccable management, because to manage all those things is really complicated. And even if you organize this system of people who will be able to sit with your child while you are working, it's indeed not an easy thing to do. We do not live in the perfect world, and we realize that we have work and many women here who are IDPs and who don't have a partner who can support them, meaning that they indeed are just by themselves with a kid. But if a woman is capable of doing this, then this also requires some efforts. And that's indeed a good thing, to be able to input what you cannot input in a very short period of time. A woman can become more empathetical. That can impact the relations in the team, more concentration there is, because if I have 2 hours when my child is playing with someone, I will be able to do a big amount of work than before. And additional possibilities. Some mothers, due to those skills and efficiencies, they can receive some interesting projects, but that's not a rule. What kind of complications can be there among women? Is that women can be feeling them put aside from society and feel lonely, because they can be in some kind of isolation, especially a woman who was not prepared to what she's gonna be seeing because she saw another picture. Because mostly when mothers come to consultation to a doctor and the doctors say, I don't know, but at some point I'm that tired. I didn't know that it's gonna be so much complicated, because those things who are going through something complicated, they do not tell us, well, yes, I'm in desire in desperate situations. They say no, everything's fine. Very often women forget about their health and they do not go to a doctor with any kind of physical symptoms. And in this very research I told you about before, mostly they do not do it because there is simply no one to left a child with, and they simply don't have time. Women who breastfeed, so to say, they economize a big amount of money for the state, but so to say, I don't like it when one tells about breastfeeding when it comes to economizing, because it's unvaluable. And those women sometimes feel this kind of guilt that should not be there. But still, despite the fact that the world is counting how much money this is economizing, this is not done for GBP, for example. Approximately half a billion of women don't have this protection, and because of this, there is this low statistics. Ukraine has a high development rate, because there you have to quickly go to work, and it is really complicated to unite all this and combine. So I've been telling for 20 minutes how everything is bad, and right now I will try to talk for 10 minutes what one can do with all this, and whether it is possible to do anything. Yes, it is, and many companies already are there, but obviously that the world is moving in very fast speed, and even if you don't have a child, or if your child is already grown up and it requires less amount of time put into them, then in order to stay on the same level, you have to rush, and in order to move forward, you have to rush twice as fast. What can help is some precise personal things that a woman can do for herself. For example, to resort for some kind of consultations, and that's called consultational navigation systems, called the coaching sessions right now, and it helps to understand who I would like to be after maternity leave. Because not always a woman wants to come back to that role that she already has had. due to some kind of rethought moments to design practical skills to have and to build the support network. It's indeed very much important. And again, as a panel discussion that was here before, we talked. And to talk to friends, to talk to family is important. And what is important to talk through a mouse, not by eye look. Because before that, I really understood that you have to talk and not only to get accused. And when you recall, well, I need on Monday, on Friday, and Sunday to take care of the child, and you have to talk by your mouth why you need this. Why? Because it is complicated. Because say I want to be a good role model for my child, and yes, correspondingly to ask about this. And when we talk with my patients, I always tell them about that psychological education and explain them some moments saying that yes, it is complicated. It doesn't seem to you this way. It is indeed complicated. And I ask them, can you please tell me what did you do out of those things for yourself for the last time? And that's indeed the question that puts them all on hold. What did I do for myself? And very often women imagine this for myself. Well, to go to Maldives Islands, to leave a child for a husband, to go to a big shopping, to sit on the seashore and to drink some coffee. But in the reality, this kind of life consists out of small things. And these small things, it is possible to keep up with them. And when we still talk about those things for ourselves, we talk about some real moments. What can this be? It can be, well, to do the modern PT, because a lot of people think that to go to sport, it means to go to CrossFit. No, not necessarily. Just to do a little bit of PT after the joint sleep with a child. It's also, again, to put on a comfortable clothes, not just dirty pajama. Meaning that we all will have this kind of list to recall what you love to do before you have a child and you roll, because indeed that's a good support.
People often think about it, thinking about mental health disorders, but we can also do these things to prevent them. It's important to have breaks when it's possible to have breaks. If you have a chance to ask someone to spend time with a child, or if a child is sleeping, you can use this time not to do something for someone else, but do something for yourself. This is a screenshot of my schedule. These are just my personal stuff, personal tasks. On the first day, I had to send the utility indicators. So there are some sport training sessions or English. So this is my private schedule. It's important to have your private one. Another thing is to avoid unrealistic expectations. If you enjoy talking to people, it's great. Taking into account, have dedicated time for it. Another important thing is the being touched, but not only to care for someone. Oftentimes, women think about hugging someone or taking care of someone based on their needs, on the need of that person. But it's important to be touched when it's about you. For example, to have massage. Sometimes when women come to me, I tell them to have these massage sessions. It's also important to be prepared. Researchers say that a woman who was prepared for delivery, who knew about all the processes, all the consequences. For instance, if they see what delivery is, when they talk to other women who's been through that, are in a better place than those who didn't know about it. We cannot make a woman responsible for everything that happens to them, because without having the institutional support from the state, the employer, it's very hard. It's hard to place all the responsibility on a woman. For instance, if there is no place in the workplace for her to take care of her need. If the employer is interested in that woman to come back to the working place, and but the employer has to be interested because they need good employees. I think people don't know the statistics that Anastasiia has shown about the demographic situation in Ukraine. And so they are not aware that they have to create all this support system for women so that they feel comfortable in postpartum after the maternity leave. And the important thing is to ask a woman, to ask her, what would be helpful for you? When I came back to my work, my baby was 8 months old, and my employer asked me how to organize my own schedule. Because a woman has a lot of things in her mind, when to feed a child, when to put a baby to sleep, and so on. Another important thing is to create comfortable conditions. For instance, to have a room to feed a child, to do breastfeeding. It will benefit the health of a woman or a baby. It's important to have these lactating rooms with the fridge to store mother's milk and the equipment and so on. WHO has even introduced a new term, which is positive postpartum experience, is when the families receive information from motivated medical professionals that healthcare system sees their needs and respects their cultural context. So if you need to work, we respect it, and we need to create the necessary conditions for you. That also encompasses social support, services for childcare. So can the state payments for mothers stimulate childbirth? We see that its effect is not long term. So the thing is, oftentimes mothers want to return to their job when their child is 1, and the state pays 8,000 hryvnias, but there are no kindergartens, no state kindergartens that can take these young children, and the private kindergartens are much more expensive. We can see the statistics on family database. In Ukraine, there is a leave, 2-week leave for the delivery period. And unfortunately, not always men use this possibility to take this leave. Our strategy is to inform the society, to show people that this problem is there, that this problem exists. It's also important to debunk the myth of an ideal mom, because it's something that's impossible. And I'm very grateful for the chance to talk about this topic, and that it is here, that we can speak about it together. Thank you so much. Every word resonated with me. I returned to my job when my daughter was 6 weeks old, and I'm still breastfeeding, and I faced every problem you've mentioned. Thank you so much. You can ask one question if there is one. Awesome. Thank you so much. It resonated with me too. I'm a working mom. I have 3 children. I have a comment. You say that people say that you're lucky that your husband helps you. I'm also lucky, but I believe it's important to inform the society, to start with awareness raising, because I see that people in my environment don't involve men in childcare, and Ukrainian women are very much used to be self-sufficient. But I believe it's important to start with partner delivery, then proceed with involving the man in all the stages of taking care of a child. Thank you so much for raising this crucial issue. I believe that with common effort, we can change the situation. And thank you for emphasizing that we need to involve men in it. Invite the next speakers, our cardiologists, the co-founders of the NGO Lady in Red, met them in social media, and they speak about cardiovascular disease in women, and I'm very much fascinated by them. So, Daria, Korchahina, Vitalina, Ivachevska. Good afternoon. The medicine of the 20th century was written by a man's hand and avoiding women. In the 70s, initiatives, very creative acts, committees on protecting human rights in clinical trials. But by the end of the 70s, FDA refuses pregnant women to take part in the clinical trials. So all the clinical trials eventually are focused on the average man. What do we have in result? We see that when women experience heart attack and they tell about their atypical symptoms, they cannot be treated right because these symptoms are not taken into account. Women are also much more often face complications. Unfortunately, even in the 21st century, 1/3 of women take part in clinical trials. For a long time, medicine was focused on men. Can you imagine? Just imagine the US, the 60s, the Sunday schools where women are taught how to take care of the heart of their husbands. There was also a term, bikini medicine. By reading the international literature, we've realized that we pay too little attention to non-traditional factors of cardiovascular diseases connected to gender. We've realized our dreams are not enough. We need to act, and we've created all Ukrainian project of ambitious doctor that grew into NGO, Lady in Red. Our organization is registered, and we have plans for the future. Together, we created a community that is growing based on the sincere desire of women to change both the medicine and the society. We are united not only by our profession, by also by the belief that we can be vocal and we can speak about women's health and research it as much as we need. This is a project to give birth to ideas and to implement them, to encourage your colleague and inspire each other. Everything starts with risk factors. There are traditional factors of cardiovascular diseases and non-traditional. There are some factors we cannot influence. This is age, sex, and race. All the other factors can be modified. Your lifestyle, other diseases, but we don't pay attention to non-traditional risk factors. In order to speak the same language, we need to understand the difference between sex and gender, because sometimes we confuse them. Sex is our biology, is our histology and anatomy, hormones, chromosomes, but gender is society. These are about the roles, the expectations, and what we are forbidden to do. Of course, men's heart and women's heart are different, and that's based on the sex difference. But sometimes we speak about some restrictions in medicine which are based on gender. Non-traditional risk factors associated with women can be associated with different periods. It's puberty, pregnancy, menopause, lactation, and so on. But non-traditional risk factors associated with gender are based on social expectations, stress level, accessibility of medical assistance. And it's a good reminder for us, for researchers, for doctors, that cardio health of a woman is not static. It's influenced by the stage this in the life of that woman, and it's important to understand the influence of the society that is sometimes unseen but yet powerful. Every stage of women's life is special and is important. Every stage has its rule and prohibitions, but we need to understand that the most important to save women's life is awareness, which is not enough today. There is common myth that women before menopause are safe from cardiovascular diseases. When we speak about period, if that starts at early age or later age, is a good predictor for the CVD. That shows us how important it is to pay attention to the non-traditional risk factors when we speak about CVD prophylaxis in women. Migraine, breast cancer, oral contraception, depression, anemia, autoimmune diseases, different specialists can treat these diseases. These are obstetrician, gynecologists, ultrasound doctors, but all of these are the non-traditional factors for CVD in women. Imagine a woman who is suffering from depression. The risk for CVD for that woman is higher by 50%. I believe that every one of us can meet that woman, and our task is to refer her as soon as possible or to assign her a therapy. That's why we created a questionnaire to assess the risk factors of CVD for women in Ukraine. We can show you some intermediate results based on depression. And it's not surprising that even that almost half of the women acknowledge that they either have been experiencing depression or they are right now experiencing depression. It's not just a psychological problem, it's something we experience right now. And for young women, depression can influence them even more than their genetic structure. So we ask you to join us during our research. It's 100% anonymous. Our previous speakers have said that we provide different statistics, but it's not our statistics. So let's create our own statistics together. Planned pregnancy is an ideal option, but it's not always possible. So in the first trimester of pregnancy, weeks 11, 13 has to be monitored, examined, and we need to pay attention to maternal characteristics, age, weight, race. Is that the first pregnancy or second pregnancy, family, disease history, and blood pressure. It's very simple, but it helps us identify women who can suffer from chronic arterial hypertension. So English literature says that pregnancy is a good time to pay attention to these factors.
Arterial hypertension among women during pregnancy also has its own peculiarity, and the right classification allows to understand these differences, and most important, to design the plan of the correct treating of these women. So while we know that there is a existing or chronic hypertension. Chronic one is appeared before the pregnancy or before the 20th gestation week. And mostly this kind of hypertension really stands more than 6 weeks longer after the birth and can be accommodated by inuria. So the hypertension is a hypertension that appeared after the 20th of week of gestation. It can vary, meaning that within the primary checks, we can identify the increase of the arterial blood pressure. But with the next checks, this level can be normalized. However, we have to be more precise to this women, because exactly they have 40% more chance of having eclampsia. It's not about the increase of the level of arterial blood pressure, but it's about also acute diseases such as the liver, kidneys. There can be some kind of neurological diseases. The pleasant obstacles can be changing that will favor the prolonging or deadly birth rate. And when it also comes to preeclampsia, that's exactly that case when a patient already has chronic hypertension, but during pregnancy she has these symptoms characteristical for preeclampsia. But there can be case when we diagnose the increase of blood pressure after the 20th week, and we don't know what was before. In this case, we do non-classified hypertension, and these women require additional check 6 weeks after the birth, with the fact that if the pressure remains, then we give the diagnosis of the existing or chronic hypertension. And if there is no pressure after 6 weeks after the birth, it is requalified into arterial hypertension. Cystical. Next one, preeclampsia. That's not the increase of the arterial blood pressure. It's not just a complication of birth or pregnancy. This is what can impact and has consequences for the woman during all her life. 8% of pregnant women have an preeclampsia. And this is twice as multiplies the risks of the sugar diabetes, cardiovascular diseases, and other cardiac pathology. It increases 4 times the risk of chronic arterial hypertension, the increase of the level of arterial pressure during life. And you just imagine 3 times it multiplies the risks of the cardiovascular death. And preeclampsia doesn't end up with a pregnancy, unfortunately. In the majority of cases, it leaves the traces on the health of the woman. Among the women with the preeclampsia, the cardiovascular factors appear 10 years even before than after the what's called normodossive pregnancy. These kind of factors as insulin resistance, arterial hypertension, dyslipidemia appear among women when she is still young, meaning that systematically the check of cardiovascular risk is not just formality. This is a possibility to preserve the health and life of this woman. And this should be done at least 1 time per 5 years, starting from 35 years old. Preeclampsia is an independent factor of a risk of myocardium of the left stomach. A woman who goes through ultrasound and echocardiography, this can be identified. And just imagine a patient with preeclampsia is 14% of the risk of having it, and a normotensia, and the pregnant one who didn't have the arterial pressure going up is only 6%. Why is it important? Because based on it all is progressive and leads to cardiovascular diseases. And just imagine that this can be a woman who is 30, 35, 40 years old, who is not aware and doesn't know about this risk factor. However, at the same time, the cardiovascular diseases is progressing that already should be prevented. And in some cases, even medicamentos tablet therapy could be assigned. It is known that the health of the heart and brain are interlinked. That is why hypertension complications of the pregnancy is not the factors of the cardiovascular diseases, but also the possible future cognitive disorders. In such a way, hypertension disorders of the pregnancy increase the dimension appearance for 38%, and the vascular dimension in 3 times, and the realization of this allows to do the prevention of this, and that's what we would like to put the biggest emphasis on. It's not a story of those kind of scaredness of pregnancy, but the idea that simply the check of the arterial pressure before the pregnancy, during the pregnancy, can ensure both healthy cardiovascular system and also to avoid cognitive disorders. We sometimes talk about cognitive disorders without thinking that even young women can face this. Why is it important for us? This is important not only for our families, it's important for women to be able to feel, to follow the recommendations of the doctor and to be able to measure it completely. Preeclampsia is not an independent factor of risk in the long-term perspective, meaning that we know that sometimes there can be sudden heart death when this arrhythmia can take a life of a young woman, young mother, a colleague, or your grandmother. This is important. That is why one has to timely do the electrocardiography. For this kind of patients, take into account their gynecology and obstetrician analysis. There should be 1 day checks in order to cross out those rhythm disorders. Not always a woman can say that I have the rhythm disorders. She can have the kind of suffocation, butterflies in the stomach, and these can be already this kind of life-threatening arrhythmia knocking on the doors. One of the 12 pregnancies are being complicated by preeclampsia. Just think about it. This is every 12th woman in this hall that gave birth. And mostly this is all happened without precautions and can be the threat both for life and health of the mother and health. And the first step is to understand the personal risk. And for the woman is to survive, and for the doctor is to avoid complication. Now, obviously, the checking of the blood pressure can simply help to the life of those two people, doctor and the patient. The awareness, and again awareness. With all these red flags during pregnancies, one should be aware not just all the medical stuff, but also woman herself. When she has with eye disorder, or if she has a headache that is not possible to remove with the tablets, if she's having vomiting after the 20th week of gestation, the pain in the stomach, the swallowing of the face, and the suffocation, this can be those red flags of eclampsia, a very threatening state for a woman. Among women with hypertension disorders of the pregnancy, it is clear to have the clear plan after the birth. The first stage anticipates the home monitoring of the arterial pressure and the early post-birth visit that should happen from the first up to the 10th day after the birth giving. And this is a visit at which we can adjust the previously assigned treatment and to support a young mother. The second stage is to visit to obstetrician. That should be on the 3rd week, and the 3rd stage is a long-term observation that starts from the 6th week and up to a year's time. And every time of these control checks, it is important to check both the level of arterial blood as well as anthropology and lab indicators of a young lady. And also it is important to understand the psycho-emotional state of our young mother, because the risk of increase of preeclampsia, eclampsia, that can impact the traditional factors that have to do with this sex and those that have to do with the gender. A woman can lose a workplace or some kind of having economical issues or problem. It is already acknowledged that the stress with the argument with the mother-in-law is a factor of that risk of cardiovascular disease among women. But we don't have to threaten a woman. We have to stimulate her towards the change of the way of life, towards physical exercises during pregnancy and after the pregnancy period. And it is important the duration, the stages of implementation. The most important is that physical exercises decline the level of arterial pressure. But at the same time, this is a big test for the body of the mother. The multi-fruitful pregnancy has to do with increased amount of cardiovascular disease, and already at the pregnancy level, the rates of diabetes can be increasing. This kind of factors as the family tendency towards these diseases, the increase of the weight of the mothers, the usage of recreational technologies, increase the possibility of the multi-fruitful and one can work with this at this stage. If you can help a lady to normalize her weight of the body, if you can advise her on reproductive additional technologies, we already are working towards the decline of these risks. And when it comes to health of the mother after the birth, this is also our area of responsibility. And again, we are coming back to arterial blood pressure. This kind of woman requires a regularly check of the level of arterial pressure. It just seems everything is logical. A lady with one fruit in her body doesn't have any increased arterial blood pressure, meaning that she doesn't have any risk of cardiovascular diseases and complications. And no recommendations, cardiology recommendations, write about this, but don't know about genealogical. But a woman with the twins, with a multi-fruit pregnancy, even with the absence of the risk of arterial risk, has her risk of having cardiovascular diseases increases in 2. A woman who had one fruit in herself but had preeclampsia or eclampsia during pregnancy, her risk also increases 6 times. A multi-fruit pregnancy increases all 8 times, and this all is during 1 year after giving birth. Every period of the life of a woman is indeed a new world with its own rules. Women within 45 years, in the majority of cases, are simply flourishing. But unfortunately, that's exactly that very age when the premature or early menopause can happen. And we all know how it impacts the health. The increased accumulation of pro-enterogen liptoids increases, and it is not possible to reach that enough level of lipoproteins, and the cardiovascular diseases risk is increasing. Also, we have to say that the factor of atherosclerosis and atherosclerosis, that's genealogically sad indicator, as that doesn't change during life. And what does menopause has to do with this? During this test, it was proved that women with menopause, this very indicator that was not supposed to change during the whole life, can still go up. And our own research, whose results were published in Polish medical magazine, also proves this tendency. And despite all this, menopause is not the end, it's just a new phase. And the awareness and the realization of those risks can make it easier for the health of the heart and vessels. How can we decline the risk of the cardiovascular diseases and complications among women? It goes without saying that by increasing the level of awareness. That is why we created an NGO. That is why we urge everyone to get united, the doctors of all specialties, to listen to another opinions, to create the handouts, to create the questionnaires, simply to understand our local situation. And take into account that statistics to try to impact the cardiovascular forecast for our women. And for that time, when our NGO exists, we already have created these events, joint events for cardiologists, endocrinologists, obstetricians, and we already see some positive effect. While accumulating the anamnesis, the obstetrician, they emphasize the attention of the women that cardiovascular pathology can appear in any age, not only with menopause. And they refer to cardiologists in order to modify these factors that it is possible to modify and to do the impingement in order to decline the risks and to improve the cardiovascular health, quality, and the longevity of life. Meaning that prevention medicine should be in priority. And at these very QR codes, you can meet and see our Instagram page. And those who haven't yet filled in our questionnaire, we kindly ask you to. Thank you for your attention. Thank you so much for this very report. I already got registered and filled in the questionnaire, and I urge everyone to do the same. And thank you so much for sharing this valuable information with us. Perhaps right now we have only time for only one question, and the rest of them you will be able to to ask either personally or in the corridor. Thank you all so much for this presentation. My name is Eugene. I'm cardio surgeon, and the question I have, well, it will consist out of several stages. First one is, why in this very researches it was mentioned that the argument of the mother-in-law and not just the domestic argument can lead to this? Well, quite an interesting question. When we posted out the questionnaire, we precisely received the maximum amount of questions like, why is it mother-in-law? Why isn't it daughter-in-law? And mostly these were written by women of the older ages, but it was written down mothers-in-law, meaning that we will perhaps create a questionnaire how among our women it was, whether this kind of argument with the mother-in-law leads to this. Okay, next question comes out from the first one. I also have a wife who is also the surgeon and proctologist, and when she was pregnant, sometimes she had night shifts. Are there any kind of researches that would identify that the night shifts of the pregnant women can provoke the development of preeclampsia or to increase the cardiovascular risks? Because at the beginning of somebody's presentation, we said that the disruption of placentation can also lead to this stress that also doesn't favor the placentation. Right, there are articles and publishments that those who work in the night shifts, they have this kind of circadian rhythm being disrupted, and this all launches this, I would say, and can increase the level of arterial blood pressure. And if there are additional risk factors, this all will be reinforced. That is why, yes, that's indeed those gender peculiarities of the necessity of the shifts of pregnant women during night shifts. Okay, from what period of pregnancy would you recommend to refuse doing night shifts? Well, there is no this kind of clear information about this, but we have to take into account the age of the woman. We have to take into account whether it is the first pregnancy or not the first pregnancy, whether she has another risk factors or whether she has this increased level of arterial blood pressure. How is it going? Does she have this kind of gestation disorders? This all should be taken into account, but there is no clear answer that, yes, started from this term of pregnancy, we have to prohibit having night shifts. But if a woman can avoid this kind of night shifts, then definitely at the very beginning it is preferable to avoid them. Right. What will be taken into account whether there was the increase of the arterial level of the woman before the pregnancy, whether she was controlling it, and precisely according to the calculator, while putting in your own data, the calculator will be able to measure these risks. Well, it's really complicated to discuss this very question with the employers. Well, that's the point why we assemble all here and to look out for the solutions to these questions. Thank you. Right. Excuse me so much. Let us start with what is placentation and when it appears. It appears in the moment of implantation of the egg into endometria. It appears even before a pregnant woman knows that she is pregnant. And the pathology of invasion of chorion in endometria and those spiral arteries that meet up with another arteries, it appears, so to say, at the second and even earlier than the second week of the pregnancy. If you recall embryology, the implantation starts on the 7th day from the very first stage. That is why we cannot impact this. That is why a pregnant woman should stop those night shifts and to work through her circadian rhythms before the pregnancy in order to do the prevention of the invasion of chorion. Well, it was quite interesting, quite informal. And if we already have talked about this, let me also add 30 seconds from myself, because when I was talking with my employers, because they didn't want to let me go from night shifts, I had to go to to HR, and definitely not the doctors, but those people who are quite familiar with the night code. They say that the pregnant ones have the right not to take any night shifts, and this is absolutely regulated on the legislational level. God bless. Not every employer reads this. They don't like this kind of note, but still legislatively it has been marked.
The last lecture for today is by Oksana Khrystuk, senior psychologist of Lviv Center together with you, PhD in psychology, works in the Internal Affairs University. It's always hard to be the last one, but I'll try to keep it short, and I believe you can make it. I'm a representative of Lviv Center that aims at psychologically support people during the war. This is a center by NGO Together for Ukraine. According to WHO data, in Ukraine, as of 2025, there are 9.8 million of people who either are at risk of mental health disorders or already have them. How many women are among them? It's hard to say, there's no data for it, but we know that women often ask for mental health support, although men are almost catching up, but women ask for this assistance much more often. I will speak about based on the experience of our center. I will speak about the categories of women who come to us and what are their requests. The main requests are of 2023-2025 are anxiety, negative mood, depressive mood, emotional burnout, mood swings, emotional swings, loss, and chronic stress, and traumatic events. What are the categories of women? There are 3 groups that often come to ask for assistance. The first group is the biggest one. These are wives of the military and veterans. Second category is a little bit smaller. Partners, wives, mothers, adult daughters of fallen soldiers, and those who went missing. And even smaller category, third category, these are just women, young women, middle-aged women who experience crisis situations, which are not connected with the war, but oftentimes war brings up issues that these women had before the war. And other family conflicts, anxiety about the future, and so on. So these are the 3 categories we encounter. I will later on speak about the means of work we have and what we do to support these groups. But let us speak about the balance, about what is positive. Despite the fact that women carry so much psychological weight of the war, because they have to combine different roles, they have to do a lot, they also face ambiguity. There are still some positive tendencies that we need to pay attention to. It's important. So they are that there is labor market dynamics based on WorkUA research. Labor market since 2022, when the full-scale invasion started, the labor market is recovered by 93%. A lot of opportunities arose to work, to get new skills. And these opportunities are first and foremost aimed at women. The example of this is initiative, the project by an NGO BUR, which means Build Ukraine Together in Ukrainian, and with the support of the charitable foundation Together with You, Together with Ukraine, there is a project that's called School of Female Masters. This project is aimed at facing the challenges and resolving the challenges of construction industry. Although a lot of buildings are destroyed, we built a lot of new ones. And this project helps women get new knowledge and skills and start working in construction industry. It may be strange for some people because it's not traditionally feminine trade, but it helps us to support economy and it helps women to realize their potential. The project by Lviv Center has a mission to provide psychological support for those women who are in the process of this training. Building on that, we can say that even if we face these hard circumstances, there are still ways to realize our potential. And this is being active. Activity is important. Being active is important because trauma makes us powerless, makes us passive. So any kind of activity is means to find way out of traumatic experiences. If we come back to how we work and how other centers work, and to the fact that it's important to implement mental health programs, it's important to form self-support skills. We were talking about it a lot, but let me draw your attention to specific issues. It's important to share this information on self-support through social media, through internet resources, but also through professional support in individual and group consultations. There are a lot of researches conducted by specifically American scholars. It's important to have short-term interventions that are based on CBT, on mindfulness, that we have mentioned a lot, but also on the new kind of therapy like ACT and EMDR, short-term interventions that don't take a lot of time. Research shows that they are very much effective with depressive and anxious disorders. New research of 2025 show that when people experience loss, and in order to prevent complicated loss, it's important to have social support. And this social support has to be implemented by professional support and the support by communities. So if you think about the professional support and community support, we need to single out the skill of renewing the time connections. What do I mean by that? I mean that it's important for a person to have perspective of past, present, and future because trauma messes this up. So the past is what we did in the past, our past activities, past resources. We can work on future through making plans, setting objectives, and we can work with the present through our attention to the needs of a person in present. And if we have these three perspectives in mind, we can help that person have it time perspective, acquire it. Another important thing is behavioral activation. These are very simple activities that can be implemented both individually and in groups, in communities, in professional assistance. And the next basic skill is self-regulation. We were talking about it when we thought about speeches by our colleagues when we spoke about pregnancy and breathing. So why didn't breathing exercises help a person during delivery? Because this skill is something we need to learn. We need to train it many times for some time. And only after that, it's working in the crisis moment. So it's important to involve people in that training. Self-regulation helps us to activate the function of self-soothing. It's called self-soothing. Another skill that we can single out is trigger management. Living in the time of war, we cannot escape triggers and we will respond to them. But when we know what kind of triggers these are and that we respond to them, that these are our personal triggers, we can use self-soothing techniques and we can support ourselves. Trigger management is quite important for psychosocial well-being. And all these skills also play another important role. They form psychological flexibility. That's the basis of resilience that we often talk about. Resilience needs all those previous skills. So psychological flexibility is based on the assumption that our experience doesn't make us broken, but that our experience makes us into different people. And at the end, I'd like to end my short speech by a therapeutic question that you could ask yourself and use even today. When we face a lot of difficult situations, when problems are not solved, a therapeutic question by my CBT colleague is the following one. Just focus and ask this question. What couldn't you do where you failed? What are the things that you failed in? So when we ask this question, we understand how much we've coped with. And if we could cope with the previous challenges, we can persevere in the future. We are so grateful to you, Oksana, for your lecture, for your work, which is very valuable for us. Do you have any questions to our speaker? I can see no questions, so thank you so much. Thanks a lot to all the speakers and participants. We were speaking about women health. Anastasiia will wrap up, and after that, we'll have a word session, and after a word session, we will have a dinner together. Dear friends, I'm very much grateful to you. I enjoyed this time so much. It was awesome. I enjoyed seeing you, asking questions, debating. And I believe if we had more time, we could talk for hours. And I hope that this these conversations will not be limited to this forum, that we will not forget about each other, but that we will keep in touch. We'll share our contacts, follow each other on social media, and that we will be able to do joint projects, asking each other questions, feeling fulfilled by what we do, and developing for our patients, family, and friends. Thank you so much. I'm happy to be here. It's not a goodbye. We can talk to each other outside, take pictures. This is the last lecture for our second and final day of the forum. And see you next year.